DIEP flap. So this is one of my BRCA patients with breast cancer, and so we did bilateral mastectomy. You can look at the belly before and after, look at the breast before and after, nipple areolar reconstruction. Another patient, you look at her breast, we try to make them better than they were before. Now I've got scars, but I had to get rid of some of that skin, and these scars will continue to fade. But these are her befores, and these are her afters. This is one of my physician patients, and she's a pediatrician, so before and afters. That's another patient. We did this at both of those we did at Baptist Downtown, and her befores and afters, nipple areolar reconstruction, and so these are her before and afters from DIEP flap reconstruction, DIEP flap reconstruction, DIEP flap reconstruction. Really quick, this is I'm going to spend 5 more minutes to tell you something that's new, and then I'll let you ask questions. Oncoplastic surgery, this is something for those patients that want to keep their breast, want to maintain their sensation, but they always thought that they want to change it, whether it's a breast lift or a breast reduction. I've been doing more and more of these, especially down at Baptist Beaches, and it takes involvement from the patient and from the general surgeons. That if the patient wanted to have, say, a breast reduction, if breasts are huge, it's better to do it at the time of cancer surgery than after radiation treatment. Remember, radiation affects blood flow, which is deadly. So the patient can have the cancer removed. So you can see cancer here. Patient has the cancer removed. It's confirmed that it's removed. And then a week later, we do a breast reduction. They heal, and they go on to radiation treatment, and they're done. And so they've had breast cancer surgery, they've had a breast reduction or breast lift surgery, and they now have better breasts than they had before, maintain their breast, have sensation, have their own nipple areolar complex, and have better symmetry. And because we can kind of account for the radiation changes, because you asked me what does radiation do, it also does shrink the area that the cancer is moved from. We can account for some of that so that you're going to get less discrepancy after a lumpectomy and radiation treatment if you do these things. So, anyone know what operation this lady had? These are just her afters. She does have implants. She had mastectomies, okay? Bilateral mastectomies, and I wish you could see it in a little bigger, but her scars are under her breast. And so she had nipple areolar sparing mastectomy. This is something that's new. It's a little, it's like I said, this is not standard of care today, but it's not for everybody. But she looks like she had a breast augmentation. She has no scars in the center part of her breast. She has her own nipples, her own areola, and the areola's got texture to it, like many of our areolas do, and that's something we have a difficult time recreating. And doing nipple areola sparing mastectomy, like I said, it's not for everybody. And we're still in just the testing phases. We're doing it in probably worldwide thousands of patients, not tens of thousands or hundreds of thousands of patients. But for certain women that meet criteria, small-breasted, small tumors, tumors are away from the nipple, these are the type of results we can get, before and afters, her own nipples. Before, up here, and afters, her own nipples. Before and afters, basically we've just done, an augmentation. The scar and augmentation is about that big. The scar and a mastectomy with nipple sparing and reconstruction is about that big. They're both hidden under the breast for the most part. And this patient, she left for San Diego, now on San Diego Beach. I had to get her to email me pictures back. Nipple areolar, another patient, nipple areolar sparing mastectomy. So just, to tell you, there's oncoplastic surgery, which is breast reduction and breast lift at the time of cancer, and there's nipple sparing mastectomy, and there's DIEP flap reconstruction. There's a whole host of other things. And unless unless someone recommends or you recommend that you get educated, there's a whole bunch of online sites, but it takes education to make sure that you are going down that pathway that's best suited to you. And that may mean meeting with Jerry at In the Pink and getting a prosthesis, and that really suits you well. It doesn't mean that you have to have reconstructive surgery, but it's best to, I think, know your options so that you can go forward in an educated manner and make an informed decision on what you think is best for yourself. Yes, ma'am.
5 years ago, my doctor at Baptist would not take off both breasts at the same time. And I'm mad about that until this very day. I felt like I was going to beat cancer, and I did. After 3 years of dealing with prosthesis and unfitting bras, etc., I decided to go to a plastic surgeon and have it fixed. So in putting in the expanders, when it was time to put the prosthesis in, he did a biopsy of the left, and there was a cancer again. So 30 days later, I had to go back another time. It's been very, very expensive for insurance companies and everything like that. I think it ought to be a rule that a doctor would do what a patient requests, and that both of them be taken at the same time, so you don't have to go through all this being put to sleep and everything like that. I'm satisfied now. I'm very much so healed, but like I say, that was 5 years ago, and as of 4 years ago, I had a certain lap band surgery, and I'm proud to say that I've lost 120 pounds since then. So I feel wonderful. Used to be 24W, and I'm a proud AP.
Good for you. Congratulations on both of those accomplishments. Those are great accomplishments. Congratulations on being a breast cancer survivor. Yes, I hear that a lot from patients, and basically, what someone recommends. The patient, you have to, obviously it's on us in the medical profession to make sure that we can offer whatever that the patient desires. And I think that that's changed to the most part 5 years now. I think if you go to see one of the, one of the breast surgeons, that mentality has changed as the times have progressed, and that if you opted for a bilateral mastectomy, and you don't have to have one, but if you wanted to have one, that they would say, yes, I'd offer that to you. And so, I think times have changed in the last 5 years. I think they need to change more, but I think the take-home message is as the healthcare community tries to change, and remember, there's a lot of us, empowering yourself to make a decision. If you don't like what you hear, seek out a second opinion. Meet with another general surgeon, meet with another plastic surgeon, or whatever it is, so that you really get the information. And maybe it's not the right thing to do, but I think that's going to help. Everyone can do what they want with their breast. I mean, everyone can have a lumpectomy, or patients, if they have the right cancer, it's not too big, too small, they can have a lumpectomy or a mastectomy. They don't have to have a lumpectomy, and some patients don't have to have a mastectomy. A lot of patients can get pushed into the mastectomy category just because of the size of the tumor, okay? And you can have reconstruction, you don't have reconstruction, you can have one type and not the other, nipple, areola. All those choices are yours.
The fact is, you're in an emotional state.
Absolutely.
And the doctor should be educated enough that he could go ahead and talk to you then, because you don't want to mess around going from one to another, et cetera, et cetera.
You're absolutely right.
Get your job done, get on with it.
And you're absolutely right. Like I said, it's that whirlwind, right? And so, but sometimes, I think it's important, basically to call a huddle, a football analogy, with your family, your loved ones, or whoever it is, to say, is this really what I want to do, and is this what's best for me? And empowering yourself. And we're making strides in the healthcare field to try to improve outcomes and improve patient choices and be better listeners. So.
And isn't it just recent law that you should have a healthy breast removed? I mean, and insurance has to pay for it.
I don't know that it's even law, but I think that I have never seen insurance balk at it in the last 5 years.
But they did used to.
They may have, 5 years ago, they may have had a little bit more of an issue.
Question, please. Well, my question, she sort of asked a question. I was going to ask, does most insurance companies pay for all of this reconstruction?
Yes, ma'am.
Thank you.
May I ask a question? When you do the tummy tuck combined with the flap issue, do you not have drains afterwards? I had a friend that had her breast lifted and had a tummy tuck, and she had drains for a long time.
You have drains for a week.
A week?
Yep.
So, okay.
You have drains with the mastectomy implant reconstruction as well. So the drains are just a necessary evil. It's not there forever, but yes, you do have drains. Any other questions?
I want your business card.
You're already healed. You're survived. I don't know if I can help you anymore.
I don't know about that.
Yes, ma'am. Congratulations. Well, Peggy can tell you, the last 2 years I've tried to, all of us, there's a number of plastic surgeons at all the hospitals in the local area community, and And our role is, you know, obviously to educate women on their options and educate the healthcare professionals on that their options are there. And we've all made, I think, inroads to try to address that, even just in the last 2 years. You know, and certainly 26 years ago, it was far worse. And so I think we're a little slower to come around. You know, patients are, you know, a little bit more, some are more savvier and you know, get to us faster. But we have to keep up to date. You know, we have to continue improving the techniques we use, and we have to keep up with the world. We can't get outdated, otherwise, you know, the patients are going to find the surgeons that are the most up to date. And so I think that's an important part of it. And I'm sorry to hear that experience, but
get a mammogram every 6 months for a period of time, for about 5 years, and then after that, just yearly.
well, congratulations once again on being a 26-year survivor. Maybe I'll see you at the Common race on Saturday. I'll be there.
We'd like to thank Dr. Desai for being here today for a very informative talk. Please be sure to turn in your evaluation forms.
Thank you very much.